Thanks, Sophie. Okay, Sophie, we can go to the next slide. Okay, so now we're really going to dive into Paxlovid and kind of what it is and what it isn't. So you can go to the next slide, Sophie. So Paxlovid is a medication that has two active ingredients. The first active ingredient is a medication called nirmatrelvir, and so this is the medication that's technically still under FDA review. Nirmatrelvir is the active ingredient that inhibits the viral replication. So this is the actual M-pro protease inhibitor. We're familiar with ritonavir. We know ritonavir can be used for other infectious diseases. And here again, the purpose of ritonavir is to boost the concentration levels of nirmatrelvir. It inhibits the degradation of nirmatrelvir through the CYP3A4 pathway. So again, the takeaway here is nirmatrelvir is the main active ingredient, while ritonavir is the booster. Paxlovid has been authorized by the FDA since the end of December of 2021. And so back in the fall, we had a very limited supply of Paxlovid. It became authorized at the same time as molnupiravir, and we were really expecting these medications to fly off the shelf, especially during our Omicron surge. And we didn't really see that, which was pretty interesting. I think we saw a lot of prescriber hesitancy because these medications are new. We don't know how people are going to react, that sort of thing. I'm really excited that we finally have it where the EUA is amended and pharmacists can start prescribing this medication. So again, long story short, this medication's been available for patients to treat COVID-19 since, I'm going to say early January is when we started distributing these medications. So who's eligible for Paxlovid? We talked about how you have to be at high risk. You have to have risk factors that would cause you to progress to severe COVID-19, but it's also authorized for all adults and pediatric patients. So anybody over the age of 12 years old who weighs more than 40 kilograms is eligible for treatment. We don't have any information about the treatment of COVID-19 in anybody younger than 12. So again, this is not a medication that can be used outside of these guidelines. It really is, do you fit the criteria or do you not? So 12 years and older and 40 kilograms and over. And then again, patients must have a positive COVID-19 test. So this is not a medication that can be prescribed as a preventative measure. This is not a medication that can be prescribed because you have a patient that's going on vacation and they want Paxlovid just in case. That you have to have a positive COVID-19 test to receive the medication. And again, those that are at high risk for severe disease progression, including hospitalization or death. So we're really trying to scale back the severity of the disease with this medication. What's interesting to note is that this is not a medication for patients that are already hospitalized due to COVID. If you're already hospitalized because you have severe COVID-19 illness, this medication will not help because it's really important that we start these medications early on to prevent that viral replication. We have seen cases where Paxlovid has been started in the inpatient setting. Patients obviously can be hospitalized for other reasons outside of COVID-19 infection. And so we have had patients that are in the hospital for, XYZ surgery or for something non-COVID-19 related, and Paxlovid can be treated in those patients if those patients have mild COVID-19. But I guess overall, for patients that are hospitalized with COVID-19, this is not a medication for them. So this is, again, a medication primarily used in the outpatient setting. Next slide, please, Sophie. So when it comes to, prescribing Paxlovid, what is the dose? What does it look like? How do you, there are two medications in here. What does the package look like? And so I talked a little bit about how the kidney function comes into play when we talk about Paxlovid dosing. So the medication nirmatrelvir and ritonavir are going to be co-packaged together, and they'll each, think of it as like a Z-Pack or any other packaging that comes with the tablets kind of already in place, like a Medrol dose pack or something like that. So the medications you would just pop out, but it's really important that when pharmacists are prescribing these medications, you're assessing patient renal function. And that's because this is dose adjusted based on renal function. So if you're I guess we'll get to that in a couple slides, but the primary dose, the regular dose for somebody that does not have impaired kidney function would be 150 milligrams of nirmatrelvir. 300 milligrams of nirmatrelvir with 100 milligrams of ritonavir twice a day for 5 days. So that would be 2 tablets of nirmatrelvir and 1 tablet of ritonavir taken together twice a day for 5 days. So 5 days is the full course of treatment. Again, it's very important that this medication be initiated as soon as possible. If the patient falls outside of the 5-day window of symptom onset, the patient's no longer eligible for treatment. So what that means is that it's not a 5-day window from when the patient tests positive. It's the clock starts once the patient starts presenting symptoms. So asking about date of symptom onset is crucial to determine if the patient is eligible for Paxlovid treatment. So again, 5-day window for onset of symptoms. If somebody does have moderate renal impairment, the dose of nirmatrelvir is cut in half. So that means the nirmatrelvir dose is 150 milligrams with 100 milligrams of ritonavir twice daily for 5 days. How do you know if somebody has renal impairment? Or what does that mean? Per the EUA, a patient can take the 300 milligrams of nirmatrelvir and 100 milligrams of ritonavir if their kidney function is greater than 60 milliliters per minute, if their creatinine clearance is greater than 60 mils per minute, or their eGFR. If a patient has a creatinine clearance or eGFR between 30 and 60 milliliters per minute, that's when they get the reduced nirmatrelvir dose, and that's when they have renal Paxlovid dosing. So again, between 30 and 60 milliliters per minute of creatinine clearance or eGFR is when you would prescribe the renal Paxlovid dose. For patients that have severe chronic kidney disease, if their creatinine clearance or eGFR is below 30 milliliters per minute, this medication is contraindicated. So assessing kidney function is a criteria for prescribing this medication. This is a webinar for pharmacists, so I expect we have a lot of pharmacists here. So if you dispense Paxlovid, I'm sure that there have been times where maybe there hasn't been a dose written on the prescription, or you have to clarify with the provider which dose do they need. And so it's really important that we encourage all of our providers, including pharmacists that do prescribe Paxlovid, to write the dose of the medications on the prescription. That way, whoever's dispensing the medication knows which formulation to provide the patient. And that's important too, because Paxlovid will come, like I said, it's co-packaged together like a Z-Pack or a Medrol dose pack. There's a normal dose package, and then there's a renal dose package. So you don't have to adulter the package anymore. The Pfizer manufacturer has come out with renal dose packaging. So you can just simply take a box and dispense that medication for renal dose patients, renally dosed patients. Paxlovid, it comes with some baggage. It's not a clean drug. It's not it's not a drug that's, it's well tolerated, but there are some things that pharmacists have to assess for safety for, including CYP3A4 interactions. So like I said, the ritonavir inhibits the degradation of nirmatrelvir, and nirmatrelvir is going through the CYP3A4 pathway for degradation. So obviously that is going to cause a lot of drug interactions if patients are taking any CYP3A4 inhibitors or inducers. So assessing and understanding the CYP3A4 interactions is going to be crucial when it comes to prescribing Paxlovid. There's also a caution in the EUA for any patients that have pre-existing liver conditions, and that's because we know the ritonavir medication can be hard on the liver. So it's important that the pharmacist is evaluating liver function values. One other point here when it comes to the ritonavir is that it is important that pharmacists are asking and assessing if the patient has untreated HIV, uncontrolled HIV, or if the patient could is at risk for having HIV that could possibly be unknown. And that's because we don't want to create any superbugs with using ritonavir in a patient that has uncontrolled or undiagnosed HIV. So again, we don't want to create any HIV protease. We don't want to create a bug that would be resistant to HIV protease inhibitors. So that's another really important piece that it's important for any prescriber to assess prior to prescribing Paxlovid. There is a question in the chat that I'm going to ask really quick. So what education is going out to prescribers, because we're seeing a lot of providers who don't know the criteria for prescribing and who have been somewhat confrontational when we've tried to do our due diligence after receiving a prescription. So thank you, Travis, for that question. So we continuously, send communication out to providers, and we host our webinars and open forums. And it's really all about educating the providers about prescribing this medication. When I was in pharmacy school, I learned that it takes a physician about 7 years to adopt new guidelines. And so I don't know if that statistic is true anymore, but I think the takeaway was that, it takes time for any provider to adopt new practices. And when it comes to prescribing Paxlovid, I mean, this is exactly what we saw in the beginning. Prescribers there was prescribing hesitancy because they were unfamiliar with it. So Travis, we are doing a lot of education. We're continuing to do our outreach. I hear the pharmacy community. I've heard, I've had more than one person come to me saying that, they have to reach out to the provider to ask what dose, or get clarifying information, even following up about the patient's kidney function because they're not sure. So I understand that it happens, but we are, trying to educate the provider community as best we can. And we'll take this back to our team too, to see if there's additional opportunities for education and outreach that we can do. Thank you, Travis, for the question. Okay, Sophie, I think we're good on this slide. I think we can go to the next one. So like I said, it's really important, obviously, to assess patients' renal function. So we have it on the slide here. Somebody that has normal renal function, eGFR greater than 60 mils per minute, you can prescribe the normal Paxlovid dosing. For somebody with moderately impaired renal function, meaning eGFR between 30 and 60 mils per minute, prescribe the modified dosing, the renal modified dosing. Anybody with a eGFR less than 30 mils per minute, Paxlovid's contraindicated, and then that's when the pharmacist would ultimately need to refer the patient elsewhere for care, which we'll talk about in a few slides. Okay, next slide, Sophie. So another topic that's been coming up in the media lately is cases of COVID-19 rebound. So I wanted to bring this up to the group just to talk about COVID-19 rebound really quick. In the sense that so COVID-19 rebound, it's been termed Paxlovid rebound. What we're seeing is, well, I guess COVID-19 rebound is the reoccurrence of symptoms of COVID-19 infection after completing or after testing negative, and then a patient may test positive again, or those symptoms may, come back. It's interesting because COVID-19 rebound is a phenomenon that occurs in patients that have not taken Paxlovid, but it also occurs in patients that have taken Paxlovid. So some people are terming it COVID-19 or Paxlovid rebound, when in reality, it could just be normal progression of the infection itself. COVID-19 is a very new illness. It's a very new virus. We don't know all the information yet, but again, we have been hearing cases of rebound COVID-19, and it does appear that it's occurring more frequently after patients complete courses of Paxlovid, but we don't have enough data to directly correlate Paxlovid use and COVID-19 rebound. So we can't say that there's a cause and effect there quite yet. That may be true in the future, but right now we don't have that information. What I would recommend to any pharmacist that wants to prescribe Paxlovid is educate your patient about the risks. So there could be a risk of rebound infection or rebound symptoms after taking Paxlovid, but that risk is still there even if they don't take Paxlovid. So regardless of the treatment course, I would just educate your patient about the risks versus benefits of the treatment, and risks versus benefits of not getting treated. So that's a conversation that you can have with your patient, but we did just want to bring it up to the group here that, COVID-19 rebound is a phenomenon that is being monitored by the CDC, and it's a conversation that you can have with your patients. Okay, next slide, Sophie. So even though COVID-19 rebound may be appearing more frequently or maybe presenting itself more frequently in patients after they take Paxlovid, NIH and CDC and HHS, they all continue to push the same message that Paxlovid continues to be the first line treatment for patients that have mild to moderate COVID-19 and for patients that may be eligible for treatment. So even though there may be a potential risk of COVID-19 rebound, again, Paxlovid remains first line therapy or first line treatment. There's no evidence to support that if a patient is diagnosed with COVID-19, takes Paxlovid, and then experiences COVID-19 rebound, there's no evidence to then continue Paxlovid treatment or reissue Paxlovid treatment. So repeat course of Paxlovid is not recommended. If a patient becomes reinfected with COVID-19, the proper care would be symptomatic care at that point. And then most importantly, rebound is not associated with increased risks of hospitalizations, death, or more severe disease. So it appears that if somebody does have COVID-19 rebound, it's at least at the same, it's as mild or moderate as the original infection, if not less severe. So that's a good thing. And then it is important that pharmacists understand that if patients do experience COVID-19 rebound after taking Paxlovid, that the pharmacist is, should be reporting those occurrences to Pfizer and the FDA. And we have a couple of links here, and we will share this slide deck with everybody here after the call. Okay, next slide, please. So because the CDC and HHS have been monitoring the situation, the Paxlovid EUA has been amended to include a section about viral RNA rebound. And so this is essentially just a snippet in the EUA to acknowledge that COVID-19 rebound may be an occurrence after Paxlovid treatment. So what you may find from patients, I guess COVID-19 rebound is characterized by, symptom onset or a positive COVID-19 test on day 10 through 14 after treatment stops. Yeah. So again, it's not associated with hospitalization or death. And so again, just weigh the risks versus benefits of treatment or no treatment. But again, Paxlovid is first line therapy. Next slide, Sophie. Okay, so the big update and why we're here today to talk about Paxlovid is because on July 6th, the FDA revised the EUA to authorize pharmacists to prescribe this treatment in particular. It's important to know that pharmacists are authorized to prescribe Paxlovid under two conditions. The pharmacist must assess the patient's health records, and those health records cannot be older than 12 months. The purpose of those health records is so the pharmacist can determine if the patient needs the regular dose or the renally adjusted dose, or if Paxlovid is contraindicated. So the pharmacist must assess renal function prior to prescribing Paxlovid. The pharmacist must also assess hepatic function just to evaluate if ritonavir is appropriate for the patient as well. What HHS has said is that no matter how the pharmacist gets these records, as long as they're no older than 12 months, a pharmacist can use those records for evaluation. So the patient can bring in their own records. They can either be on paper, they can be on their EHR on their phone. The pharmacist can call the primary care doctor and get those labs. For whatever reason, the patient could go to a lab, get their labs drawn, and bring them back to the pharmacy. However it happens, but the pharmacist must assess renal function prior to renal and hepatic function prior to prescribing Paxlovid. The other condition under which pharmacists can prescribe Paxlovid is having a comprehensive medication list from our patients to assess drug-drug interactions. I think this goes without saying. I think we wish every patient would have a comprehensive medication list every time they came to the pharmacy. But this is, again, really important for pharmacists who are going to be prescribing Paxlovid to do a thorough drug-drug interaction, because there are many severe drug interactions that we would want to, catch prior to initiating treatment. And important that it includes over-the-counter drugs as well. I would expect that, not every patient who's coming to your pharmacy to be prescribed Paxlovid would be your own patient. So if you do adopt this service, I would, certainly set the expectation with patients clearly that this is documentation that must be provided in order for the service to be delivered. If the above criteria cannot be met, if you find that a patient does not have either of these records, a pharmacist cannot prescribe Paxlovid. Again, there is no wiggle room here. It's the patient fits the criteria or not. What's also interesting is that if a pharmacist identifies a drug-drug interaction, the pharmacist is not authorized to manage that drug interaction. The pharmacist must refer to another prescriber to resolve that drug interaction. So as a pharmacist, this is a great step forward with pharmacists being able to prescribe Paxlovid. It almost feels like a little bit of 2 steps back in a sense, that there are standards under which pharmacists can prescribe Paxlovid, and that pharmacists cannot independently resolve drug interactions. However, again, this is the criteria that is set by the federal government, and there's no wiggle room outside of this. So if a patient has a drug-drug interaction, a pharmacist must refer the patient out to another provider for COVID-19 treatment initiation, whether that be Paxlovid or another medication. So we'll go over a couple of the common drug interactions on the next slide, but and we'll have time at the end for Q&A. But again, this criteria is crucial for pharmacists to prescribe Paxlovid. Okay, next slide. So there are significant drug-drug interactions because nirmatrelvir is going through the CYP3A4 pathway. Excuse me. And so contraindicated drug combinations include phenytoin, amiodarone, clopidogrel, St. John's wort, midazolam, a lot of the drugs that we know consistently have very common and severe drug-drug interactions. If a patient's taking any of these concomitant medications, unfortunately, there's nothing that can be done. The patient, is uneligible for Paxlovid and must be referred elsewhere for care. If a patient is on a statin, for example, there's simvastatin and atorvastatin, there's a drug interaction, and it's actually recommended that the patient hold their statin medication throughout the course of taking Paxlovid. However, a pharmacist, per the EUA, cannot prescribe Paxlovid if there are drug-drug interactions, or if there are severe drug-drug interactions, or where medication regimens would need to be adjusted to mitigate those interactions. So if a patient's taking a statin that would cause an interaction, and it would be recommended that that statin be held, a pharmacist cannot give that recommendation. The pharmacist must refer the patient to another care provider to initiate treatment or manage that drug-drug interaction. Other drugs where it's recommended that therapy be held for the course of Paxlovid treatment include elatriptan, colchicine, avanafil, a couple others. But again, this is why it's so important that patients bring their list of medications so the pharmacist can do a thorough drug assessment or drug-drug interaction check. Adjusting concomitant medication doses. Again, you can see there are a lot of medications on here. This is not even a comprehensive, drug-drug interaction list. There are going to be times where there are concomitant medications that don't need to be adjusted, and so that's an acceptable time for pharmacists to prescribe Paxlovid if they meet the criteria. But just monitor for adverse events, and again, discuss the risk versus benefits with your patient. But again, the take-home piece here is that if there is a drug-drug interaction that needs intervention, the pharmacist cannot prescribe. The pharmacist must refer. Okay, next slide. So we're going to do a couple of case study questions because we've gone over a lot. We also have not hit on the primary question of billing and reimbursement and payment. So I'll touch on that as soon as we get through a couple of case studies. So let's test everybody's knowledge first. And so I'll dive into case study 1. So we have a 59-year-old white female who presents with 2-day onset of moderate COVID-19 symptoms. She states that she took an at-home COVID-19 test first thing in the morning and has a positive test result. She could not get an appointment with her PCP today, so she brought in her labs from her last checkup on May 1st of this year. Her liver panel was normal, her eGFR was 60, CBC and remaining CMP are within normal limits, so everything's looking good. Patient reports that she quit smoking 5 years ago and takes a pill for her blood sugar and cholesterol. Reviewing the last medications refilled, she's on metformin and atorvastatin. So based on her height and weight reports, her BMI is 40 and she does not have any allergies. So based on this information, can a pharmacist prescribe Paxlovid? Okay, we're going to give it a few more seconds. Okay, so the correct answer is A, no, a pharmacist is not authorized to prescribe this medication. So even though the patient fits the criteria, fits eligibility criteria, so she has symptom onset within 5 days, she's she's most likely over 40 her BMI is 40. She has risk factors for disease progression. The problem with this is that she has a drug-drug interaction. She takes atorvastatin, and that's a drug interaction that requires intervention to resolve. So unfortunately, a pharmacist is unable to prescribe Paxlovid for this patient and would need to refer the patient out. Okay, next slide, please, Sophie. And again, happy to take any questions in the chat too. So case study 2, we have a 68-year-old white male who presents and says, I have a bad cough and a fever started 3 days ago. My daughter dropped off one of those COVID-19 tests at home last night. She said it was positive and I needed to get medication. She works in a pharmacy across town and said her boss has been treating people with COVID. Upon further investigation, the patient has not seen a provider in over a year, does not recall ever being told he had kidney or liver problems, and states his blood pressure pill, states he did take his blood pressure pill, but that ran out 6 months ago, and he doesn't have any allergies. So again, can this patient be prescribed Paxlovid by a pharmacist? So I guess answer option A is yes, I would prescribe Paxlovid for this patient. He is not taking any medications and denies any history of liver or renal function. Option B is no, I would not prescribe Paxlovid for this patient. She does not meet the criteria for pharmacist prescribing, or C is unable. So I'm going to share the results. So the majority, sorry, Sophie, I don't know what I just clicked, but I'm trying to share the results. The majority of everybody here said, no, you would not prescribe Paxlovid, and that is the correct answer. I think this is a good question because it's a little hard to determine. We know that the pharmacist has not assessed renal and liver function. It doesn't necessarily matter that the patient attests that they don't have impairment. The pharmacist is required to review labs no older than 12 months. I can certainly understand why some pharmacists would say you're unable to determine the status. Do you need more information? That's certainly a fair answer too. But ultimately, the takeaway is no, a pharmacist cannot do anything until that those labs are reviewed and assessed. Okay, so I would accept answers B and C. Okay, next slide. Last case study. We have an 18-year-old African-American male who presents with mild COVID-19 symptoms that began 4 days ago. He reports he took a test 2 days ago and it was positive. He just now got transportation to come in, as his usual provider is much further away. He states he has sickle cell disease and is taking hydroxyurea in the past, but has not taken it in over a year. He reports as his annual checkup 6 months ago and did not have any other issues. His sister's a nurse and makes him keep track of his labs, which he presents to today, which are 6 months old. His eGFR is 68, liver functions, liver panel's normal, and he does not have any allergies. So is this patient eligible to receive Paxlovid prescribed by a pharmacist? If this were your patient, could you prescribe Paxlovid for him? Okay, so the correct answer is, it is, okay, that's what I thought. It's A. So the pharmacist is able to prescribe Paxlovid. The reason for this is because the patient fits the criteria. There are no contraindications. The patient's not on taking any medication. There may be a drug interaction with Paxlovid and hydroxyurea, but he hasn't taken it over in a year. The reason why answer C is incorrect is because his eGFR is normal, so he does not need the renal Paxlovid dose. He requires the normal renal normal Paxlovid dosing, 300 milligrams nirmatrelvir, 100 milligrams ritonavir twice a day for 5 days. So with that, thank you all for participating in our poll questions. Let's go to the next slide where we can answer a couple commonly asked questions, and then I do want to address the concern about billing, as I'm sure there are going to be a lot of questions about that. So one question that we've been getting pretty frequently is, is a supervising physician required to prescribe Paxlovid? So the answer to that is no. The EUA authorizes pharmacists as a prescriber of the medication. Under the PrEP Act, the 9th Amendment of the PrEP Act provides liability coverage to pharmacists that are prescribing authorized COVID-19 treatment. And the PrEP Act and the EUA are federal law. So they're kind of, I guess, the top of the top. So there is, it's the law of the land. It's authorized by the EUA. It's authorized by the FDA that pharmacists can prescribe this medication. There does not need to be any supervising physician oversight. There doesn't need to be a standing order or a collaborative practice agreement. Per the EUA, per the FDA, pharmacists are authorized to prescribe this medication. We've also checked in with the Board of Pharmacy. There's nothing else that needs to be done. Pharmacists can start, rolling out the service, whenever they'd like. Are pharmacists required to have NPIs, or are they required to be connected to a healthcare provider in order to prescribe Paxlovid? So a pharmacist isn't necessarily required to have an NPI. However, I would recommend that a pharmacist does get their own individual NPI number. Obtaining an NPI number is relatively easy and it's free. If the pharmacist does not have their own NPI number, they can use the pharmacy NPI number when they're prescribing Paxlovid. I guess my best practice and my recommendation would be, if you are issuing a prescription, I would write your name, sign it, and have your NPI number on there, just to let the dispensing pharmacist, whether that be within your pharmacy or elsewhere, know that you're a licensed practitioner and or practicing within a licensed pharmacy and authorized to prescribe the medication. Will state licensed pharmacists be able to prescribe both regular and renal doses of Paxlovid? Yes, pharmacists can prescribe both dose types. Again, really assessing patient renal function to be able to do so appropriately. Before we move on to the next slide, actually, Sophie, let's go to the next slide that has a couple of resources. So like I said, I'll send out these links, and these links have a lot of good information. We created a checklist for pharmacists to, quickly be able to check off boxes to understand, yes, I've met all the criteria to prescribe Paxlovid. So feel free to download that from our website, or you can click the link here. The elephant in the room, really comes to billing. So I've put a lot of feelers out with our pharmacy partners across the state, and the consensus is that this is a hard service to adopt within your pharmacies if there's not a sustainable reimbursement model. When it comes to billing and reimbursement, we're probably all aware that there are three primary pillars or stools. So there's Medicare reimbursement or insurance, there's Medicaid reimbursement or insurance, and then there's commercial insurance. So right now in the state of Virginia, pharmacists are not recognized healthcare providers under Medicaid in order to bill medical claims. So, and I guess that's true for Medicare, and that's pretty true for commercial insurance right now. So the whole saga when it comes to pharmacies and prescribing medication or providing clinical services outside of traditional dispensing is that, there's no payment model established. So I've inquired with the CDC, and they have confirmed that pharmacists are authorized to charge patients for the service of prescribing Paxlovid. However, they request, or I guess, they're probably going to enforce that the charge be reasonable. So I think it's pretty unreasonable to charge a patient $1,000 for the service of prescribing and assessing, but they really didn't land on a dollar amount. So what I will say is it is authorized and it is allowable to charge the patient an upfront fee for the service of assessing and prescribing Paxlovid. When it comes to Paxlovid and dispensing those medications in your pharmacy, the medication itself is free. We provide it from the government. The government's already purchased the medication, so the patient cannot be charged for the cost of the drug because there is no cost of the drug to the pharmacy. The patient can also not have the dispensing fee transferred over to them. So if the patient does not have insurance, the pharmacy, would need to eat the cost of the dispensing fee. There is no model right now for uninsured patients or for pharmacies to seek reimbursement for uninsured claims like there was for COVID-19 vaccines. So with that being said, if a pharmacist would like to roll out the service of Paxlovid prescribing in the pharmacy, you may do so either, for free if you'd like, out of the goodness of your hearts, or you can charge patients for the service of evaluation. If you prescribe Paxlovid, it is required, or the patient is allowed to fill that prescription at any pharmacy of their choosing. So just because they're prescribed out of Alexis Page's pharmacy doesn't mean that they're required to fill it at Alexis Page's pharmacy. As somebody that would be giving the service, similar to a doctor's office, you would issue the prescription and the patient could go wherever they choose. I think it's common sense, and it would make a lot of sense that the patient would fill it at the pharmacy that they're already located in. But again, it's their choice on where they want to go to fill the prescription. What I do know is that pharmacist NPI numbers are becoming more commonly accepted as prescribers. We saw that with COVID-19 vaccines. So I don't think that there's going to be a lot of many challenges when it comes to dispensing the medication, but I can certainly understand that there are challenges with receiving reimbursement for the service of evaluation. There is, I think what we're going to find is that the federal government or our federal partners are going to think that, they've now addressed equity concerns. There are pharmacies in almost every community, and now it opens up almost every pharmacy to be a prescriber of Paxlovid. I think what they'll find is that they haven't solved the problem quite yet, because it's not about giving access to pharmacists, it's about paying for the services. And so I'm continuing to escalate my concerns up to our federal partners. I know there are a lot of other people working on the national level, a lot of organizations like APHA, VPHA advocates on the state level, NCPA, CPESN, a lot of great organizations that advocate for pharmacists to have a reimbursement model established. I think, I mean, I can give you my opinion. I think this is a step in the right direction, and pharmacists just need to continue to push for change to carve out that payment model. Because I think, again, what we'll find is that the idea is great, but the execution is not there because we don't have payment. So with that, I don't have any other additional information when it comes to billing and reimbursement. There are mechanisms in which that pharmacists can become credentialed with insurance providers, like third-party insurance providers, and that's a process that's a business decision. You're welcome to take that course, or I guess go down that road if you are interested in doing so. But I don't think that that's an immediate fix. That takes some time. So again, pharmacists are allowed to charge the patient directly for the service of evaluation. As the Virginia Department of Health, it raises concerns because it doesn't meet equity needs. There are patients out there that can't afford these services. But I understand that it's unrealistic to expect pharmacists to do this service for free. Okay, so I'm going to look at the Q&A and